context. During the 20th century, the world had three viral pandemics. In 1918, the so-called Spanish flu. In 1957, the so-called Asian flu. In 1968, the so-called Hong Kong flu. Three during 100 years. In the 20 years of the 21st century, we've had SARS in 2002, H1N1 in 2009, MERS in 2012. We've also had major outbreaks of Ebola, Zika, and avian viruses. What's going on? The following comes from the World Health Organization. All experts, quote, all experts agree, changes in the way humanity inhabits the planet make the emergence of more new diseases inevitable. Constant mutation and adaptation are the survival mechanisms of the microbial world. These microscopic agents, some of which copy themselves more than 1 million times a day in sloppy ways with no proofreading mechanism to correct mistakes, will always find a way to exploit any weaknesses in systems set up for protection or defense. Recent large outbreaks just since the start of the century have shattered a number of myths about the world's vulnerability to threats arising from new pathogens and epidemic-prone diseases. As the century began, most experts believed that the exotic pathogens that cause so much misery in Africa and densely populated parts of Southeast Asia would never become a problem in wealthy countries, with their high standards of living and well-developed health systems. Then came severe acute respiratory syndrome, SARS, in 2003, a disease that took its heaviest toll on wealthy urban areas. SARS spread most efficiently in sophisticated hospital settings. The 2009 H1N1 influenza pandemic, the first of the 21st century, proved how very quickly a new virus can spread to every corner of the globe. It showed how, with all the eyes focused on H5N1 in Asia, something bubbling up on the other side of the world can be the event that actually explodes. The Middle East Respiratory Syndrome, or MERS, broke yet another widely held assumption. Prior to that outbreak, the exotic jungles and forests of Africa and the teeming cities of Asia, where people lived crowded together with chickens, ducks, and pigs, were considered the two most important geographical birthplaces for new human pathogens. Not after MERS. Camels in an arid desert setting can also breed surprises. That's a commentary from the WHO, a recent commentary from the WHO. It's not like we didn't know this was coming. The Obama administration had a number of drills for an emergency driven by a respiratory pandemic. And just a year ago, the Trump administration had a drill regarding a pandemic, which illustrated all the failures we found in battling this pandemic. Bill Gates did a TED Talk in 2015 entitled, "The Next Outbreak, We're Not Ready," something he repeated to the Massachusetts Medical Society in 2018. Gates said, "We've always known that the potential for either a naturally caused or intentionally caused pandemic is one of the few things that could disrupt health systems, economies, and cause more than 10 million excess deaths." While the problems engendered by this are and should be obvious, the answers may also be. Science has been relentless in pointing to what we need to change. The question is what we can do now to ensure that we're doing everything we can to lessen the incidence of pandemics. We'll now have our speakers, Dr. Johnathan King, starting with Dr. Johnathan King, a longtime professor of molecular biology at MIT, where he has directed NIH-funded biomedical research on viral and bacterial proteins. He also serves as co-chair of the Mass Peace Action Board of Directors and leads its Fund Healthcare, Not Warfare campaign. Dr. King.
Thank you, Bill. And Vernon, pleasure to be here, and all of you who've signed on. I want to talk about three aspects of global warming and infectious disease. One, the direct impact of rise in temperature. Secondly, sea level rise, a secondary consequence. And third, the ecological disruption. So many of the diseases that ravage humans are vector-borne. Malaria would be one of the clearest cases, where it's the mosquitoes that carry it, and as long as there are mosquitoes, there'll be malaria. Mosquitoes all insects are cold-blooded. in very cold environments, they don't thrive. It's not that you don't have a little bit of malaria as you move toward the Arctic and the Antarctic, but basically they fall off as a problem. As the temperature goes up, the range of the vectors, the range of the mosquitoes is going to increase. And a number of studies on malaria indicate that one of the consequences of global warming is going to be the increased range of the malarial parasite, which still kills hundreds of thousands a year. Now, of course, there are many other vector-borne diseases. Lyme disease, we're already seeing Lyme disease, which used to be kind of restricted down here to Long Island, is now moving up into Canada. And you can expect around the world that vector-borne diseases are going to increase in frequency and be harder to control. A second area is the secondary consequence of the rise in sea level. If you think about global areas, think about Bangladesh or Vietnam, Martha's Vineyard, or Boston, Florida. All around the world, human populations are concentrated in coastal areas. As sea level rises, we're going to see inundation of these areas. What happens when you get inundation with seawater? You get disruption of all manner of public health facilities, as flooding of hospitals and healthcare facilities themselves, but you also get kind of undermining of the water supply. And when the water supply gets compromised, then a whole other set of waterborne infections, like cholera, for example, carried by Vibrio cholera, which thrives in brackish waters. So we can expect disruption of the healthcare system, disruption of clean water supplies, to open up another arena of increase of infectious diseases that we thought hadn't no longer with us. Now, as these areas get flooded, the populations move in, they get denser. We all know that many infectious diseases like coronavirus, like flu, their transmission increases as the population density goes up, as people get closer and closer together. So just the increased crowding is going to lead to increased transmission of these existing pathogens, as well as new pathogens. The other thing that happens as the population gets driven out of their historic center is they move into areas where humans weren't previously, like tropical forests, which have bats and other animals, and we're going to see an increase in the transmission of viruses from their natural hosts, whether bats or camels or chickens or ducks, into the human population. We've already been seeing that. Many people think that the coronavirus, which is a bat virus, comes from this kind of thing going on in Asia, where people are now living much more closely to bats. Some of them are eating bats, which they didn't used to do, or eating animals that are bitten by bats. Third area I want to mention is ecological disruption. This is more sophisticated, more subtle, but many, for example, most of you know that major bird populations migrate, and their migration is historically tied to the emergence of their food supplies. Sometimes it's berries and flowers, but for many birds, for example, it's insects. And it's the it's the bird population that keep the insect populations under control. So as we get increased global warming and the bird migrations change, which is already happening, you have emergence of the insects, caterpillars, and then their predators aren't there. Well, many of these insects are themselves vectors for a whole variety of infectious agents, and we're going to see the lack of control of that. And of course, we're going to see famine. And once again, we're going to see people going into the woods going after food supplies that weren't normally part of the human food supplies. And of course, agricultural disruption. Many of the major agricultural regions of the world are fed by great rivers that are fed by melting glaciers. And as the glaciers melt away and are not replaced, we're going to see quite. So I have my phone on because I'm using the clock to make sure I don't go after 5 minutes, but then calls come in. So we're going to see famine, and that's going to cause weakening of the population and again, a new source of diseases. Now, Bill ended up talking about whether we could be prepared. I want to use a last minute to say that the scientific response to this kind of thing resides in the National Institutes of Health, National Science Foundation, Centers for Disease Control. These are not financed by Medicaid or Medicare or private health insurance or hospitals. They absolutely depend on your tax dollars that are appropriated by the Congress for these agencies. In every one of his budgets, President Trump has called for cutting of the NIH budget, cutting of the CDC budget, cutting of the pandemic task force. Why? In order to put money into the bloated Pentagon budget. So we have a situation where more than half of the tax dollars Americans send to Washington goes to defense spending, and mostly it's big contractors. It's not paying soldiers, sailors, and airmen. It's cost plus contract for Lockheed Martin, whereas that's $738 billion this year, whereas the NIH budget responsible for protecting us from all the diseases we're subject to, arthritis, heart disease, coronavirus, Alzheimer's, is $40 billion, less than 3% of the federal budget. Yes, the CARES Act that they passed on March 27th put some money in there, but it was peanuts. Another $1 billion for the NIH, a couple of billion for the Centers for Disease Control. We need much, much, much more in federal investment in healthcare. The money is there. We don't need any more nuclear submarines. We have all that we need, right? National security, those missiles are useless against coronavirus. You need real public health, real scientific research, vaccines, drugs, etc. So anyway, thanks.
Thank you, Dr. King. Our next speaker is Dr. Robbie Goldstien, primary care physician and infectious disease specialist, focusing on those living with and at risk for HIV, and who teaches at Harvard Medical School. Dr. Goldstein?
Thank you so much, Bill. And thank you to the crew folks for putting this together. And Dr. King, I will say I agree with almost everything you said there, that we need additional funding for the NIH and CDC to respond to these pandemics. I want to actually sort of start my remarks by telling you a little bit of a story about how you become an infectious disease doctor. To become an infectious disease doctor, you start in fellowship training, learning about infections that you hope to never see in your life. The idea of training is that you will learn about malaria, but you'll also learn about Ebola and SARS and MERS. You'll learn about novel influenzas. You learn about diseases that are really regionalized, and you hope that you will never have to see them. I did my training not that long ago, and I have already seen those diseases that we said were rare and would never leave their regionalized area. We see more and more malaria that is coming to this city because malaria is more prevalent and more common across the globe. We have seen what happens as Ebola left Western Africa and came to other parts of the world. And certainly we're all seeing what happened with COVID-19 and the way that that has spread throughout the world. I think I'll echo a little bit of what Dr. King said and say that there are really two ways in which infectious diseases are augmented by climate change. One is the change in temperature, and the other is the change in rain patterns or the change in waterfall that we see. And almost everything that results from those two changes can result in an increase in an infectious disease, right? So we heard about vectors, insect vectors, ticks and mosquitoes in particular, that are moving and migrating, that are bringing diseases with them. We've heard about waterborne illnesses that are more likely when we see rising sea levels or if we see areas of drought where those infections become more common. We've seen an increase in zoonotic infections, or infections that come from animals and go to humans, both because of our changing practices in agriculture, as well as our changing migration patterns. But I also want to add in a fourth part of climate change that is resulting in a dramatic amount of infectious diseases, and that is climate migration and climate asylum. So as people are leaving their home countries and going to other countries, whether that be here in the United States along our southern border, or countries in the Middle East, as they leave a country that is torn by war and go to a country seeking peace and asylum, people are being held in camps, in centers where infections are quite rampant. And we are seeing increases in the overall numbers of foodborne illnesses, waterborne illnesses, respiratory illnesses, so many infections that can lead to true mortality, certainly, but a significant amount of morbidity or harm to all of those individuals. And I think I also want to add in a non-infectious disease perspective here as someone who sees people for primary care. I am incredibly aware of the increased risk that people have in terms of their respiratory illnesses like asthma, things like cardiovascular disease, all because of air pollution. The effects of malnutrition as we have changing agricultural needs and agricultural abilities because of climate change. The effects of heat stress as we see people coming into our emergency room, as I hear patients call me all summer long as the temperatures continue to increase. And the injuries and fatalities that result from severe weather that happens all across the world, but certainly we see it here in the United States and we see it here in Boston. And the CDC, the NIH, the World Health Organization agree that this is going to result in a significant amount of mortality and death. About 250,000 deaths by 2030 to 2050 will be the direct result of climate change. Many of those from infections, but a lot from those non-infectious causes that I talked about. The last thing that I'll say, and then we'll sort of transition, I think, into a bit more that will focus on this, is that we really have to remember that the impact of climate change and of the infectious diseases that we see as a result of climate change, the impact is disproportionate. In many ways, the impact is on the low and middle income countries all across the globe, and the contribution to climate change is coming from the high income countries, in particular places like us, China, India, places that are producing a tremendous amount of greenhouse gases and are therefore making it harder for people in those low and middle income countries. In many ways, the people who are sick and the people who are poor are going to suffer the most from the effects of climate change when it comes to the infectious disease complications. And so it becomes our responsibility to certainly think about how we can avoid the unmanageable here. How do we make sure that we blunt the rise in temperature and the rise in sea levels to avoid all of these infectious complications that we're seeing? But also, how do we manage the unavoidable, recognizing that the United States in many ways, many other countries have contributed significant amounts of greenhouse gases. We will see an unavoidable change in temperature of the planet, an unavoidable change in sea level rise. How do we invest in the research that's necessary for adaptation, for first response when we see a new pandemic emerging? How do we respond quickly? For the vaccines that are going to be required for those vaccine preventable diseases and infections that are spreading throughout the world? How do we bring adaptation into this conversation so that we can really manage the unavoidable changes we're going to see?
That's you. Thank you very much, Dr. Goldstein. Our next speaker is Hajar Logan, who is an environmentalist and is part of an organization called Alternatives for Community Environment and Environment in Roxbury. And she is a environmental justice advocate, and she will be talking about the impact on communities of color.
Hi, good afternoon. Thank you for having me. I have some slides for you this evening. Let me share them. Today, I'd like to talk about the impact of environmental inequalities, and I'd like to focus specifically on Roxbury. In Roxbury, we've had an air pollution issue that, organizations and advocates have worked together on, starting as I know it in the early 90s. Roxbury, oh, let me share these slides. Hold on, I need to put them in present mode. So Roxbury, Suffolk County is a part of, the county for Boston, and Roxbury is a part of that county. The purpose of this conversation is to start to really talk about and drill down on the impact of public health disparities that often exist in low-income communities. And as a result of their existence in low-income communities, the air pollution and the toxicity in low-income communities often then exacerbates the conditions so that the public health disparities become very significant and very and have a disruptive impact on people's lives. So I have some statistics here and I will share them with you. I'll try to read them and you can read along. So Suffolk County has the greatest average lifetime cancer risk from diesel soot in the state and region, ranking in the top 1% of counties in the US, a risk 309 times greater than what the EPA considers acceptable. Chronic illnesses are common, including asthma. Did I skip it? Including asthma, high blood pressure, and diabetes. Public health disparities, I don't know what I'm doing. Public health disparities, as we know, persist in communities of color. Blacks are 3 times more likely than whites to die of asthma-related issues, and Black children have an alarming 500% higher death rate from asthma than white children. Diesel emissions, poor air quality, and associated cardiovascular and respiratory health problems affect environmental justice, public health, climate change, and workers' rights. I begin this conversation in this way, talking about public health disparities, because coupling or tying in with what Dr. Goldstein was just sharing, these public health disparities create an exponential effect in the rate of fatalities because there is so much environmental hazards. There are triggers for infectious diseases that are respiratory, like COVID-19 and SARS and H1N1. And so that asthma and hypertension create a condition in which these illnesses are more fatal in the communities that we're discussing. So currently, in regard to COVID-19 in particular, Black people make up 22% of the city, and 42% of cases where race is reported. Race is only reported in 62% of the cases. So that gives you an idea of the amount, the disproportionality in terms of the amount of people dying from the disease. Of patients where race is reported, and 57% in this study of of patients where race is reported, 57% of COVID-19 positive patients are either Black or Hispanic, according to the Boston Public Health Commission data released recently. Additionally, 61% of COVID-19 positive patients are from Dorchester, Roxbury, Hyde Park, and Mattapan. Many of Boston Medical Center's COVID-19 positive patients have presented with higher rates of underlying conditions compared to historical data, including 34% with diabetes, 49% with hypertension, and 52% with a body mass index above 30, indicating obesity. As we know, these are the conditions that help to exacerbate fatality in COVID-19 cases. I want to now discuss in addition to the fatalities that we see with increased amounts of pandemics and increased amounts of heightened respiratory illness. There are fatalities associated with air pollution in particular, and the combination of increased heat. Since 2016, the world has gotten hotter and hotter every year. And because there is a disproportionate amount of air pollution in low-income communities, that air pollution traps heat. And so it creates what is called a heat island effect in urban centers in particular. Here is a picture of Boston's heat island effect. As you can see, the difference in temperature in this study area is it's like half. As you can see, the red area is twice as hot as the low-lying area is, the area where there's a lot of tree canopy and tree density and less air pollution. We looked at Chelsea, Massachusetts, and as coastlines recede with global warming, so-called heat islands are growing. These are dense urban areas where cement and asphalt cover most of the ground, where multi-story buildings, often brick, bake in the sun, and where there are few trees. Daily temperatures in these spots can be 20 to 50 degrees hotter than in leafy suburbs. For residents of these islands, health risks rise with the heat. There is a documented result of a heat wave that happened in Chicago in 1995, and in which over 700 people died from a heat wave. So heat islands, as a result of both environmental pollutants and an increase in climate change conditions, creates a health hazard all by itself, even without a pandemic. Here's a map of the northeastern seaboard, and as you can see, the more urban areas that exist on the east and the north, on the northeast seaboard, the higher amounts of concentrations of that heat island effect I was speaking to. I would say that our next steps, and I like to have a next step slide on every presentation. And the purpose is that we always need to be thinking about how do we impact a change for our communities? How do we help each other address climate change together? I have designed handouts for what we do in a heat wave and what we do in response to the heat islands that happen and the heat waves that happen in the summer. I know that it's hard to think about right now because we've had a very mild spring. But I'm happy to share the handouts around how we check on our neighbors and how we maintain a commitment to public health for our entire community. I'm not sure how much time that was, if it was 5 minutes or more, but there it is. That's the presentation. Thank you.
Thank you.
Thank you, Hajar. Batting cleanup here is Reverend Vernon Walker, Director of Communities Responding to Extreme Weather. He's a graduate of BU School of Theology and has done additional coursework in nonprofit management and social work. He's a prominent advocate for social justice and the environment. Vernon.
All right. Good afternoon, good evening, everyone. We're so glad that you have joined us on tonight. I know some of us are zoomed out because we have Zoom meetings all day, and I know some of us are just tired and cranky from being in the house and staying in the house and sheltering in place. But we're so glad that you have joined us tonight, and I'm so glad that our fellow panelists are with us, have taken time out of their schedule to be with us and to present some really compelling and wonderful information that we need. It is very critical and essential that in this pandemic and in this time that we have to shelter in place is to think about society as it is, society as it was, and society as what it could be. Oftentimes, I like to use, when we refer to society, what society could look like, I oftentimes like to refer to that as using moral imagination. But we are living in some trying times right now. We are living in times, unprecedented times, if you will, because we understand that climate change creates a new risk. Especially for vector-borne diseases. We're living in a time where, yes, the pandemic is spiraling out of control in some states and in some countries and parts of the world. But in some ways, this may be a precursor to the climate crisis that if we don't prepare to slow down now, then it may be irreversible to slow down some of the detrimental effects that will come. Certainly, we're seeing the impact of climate change on our world today because we're seeing hotter summers, we're seeing more severe storms, we are seeing longer winters, we are seeing snow in May. Now, that's unheard of. The other day it snowed, right? Which can be shocking to some. If I could take you here, if I can, to talk a little bit more about vector-borne diseases, a little bit more about climate change, and then what CREW does all about this, and then I'll gladly step out your way. So vector-borne diseases, in case anyone doesn't know, are transmitted to humans through the bites of insects. Common vectors include mosquitoes, ticks, and flies. Rising global temperature can lengthen the season and increase the geographic range of diseases carrying insects. As temperature warms, mosquito and other warm weather vectors can move into higher altitudes and new regions further from the equator. I don't know if anybody's been paying attention, but apparently there's this new killer bee that looks really like Star Wars, like orange and black, that has appeared in Washington, but first appeared in British Columbia. But they tell us that or British Canada rather, but they tell us that folks on the East Coast, Midwest might not face these killer bees that have a sting that's, as someone described, felt like hot metal driving into one's skin. It sounds excruciating. So we're starting to see very clearly that insects are appearing in parts of the world that have never appeared before. In some regions in the U.S., warming is lengthening the season for Zika-carrying mosquitoes. I want to point out that every year, the Oceanic and Atmospheric Administration releases the Arctic report detailing the state of frozen, the state of the top of the globe. But what happens is that these archaic soil is melting quicker, permafrost is happening quicker, and as a result, it contains a lot of carbon, which we would say is contributing to the greenhouse gas effect. Certainly because the reason that the archaic soil, the archaic is melting, the permafrost is melting, is because the planet is warming at a quicker rate. So essentially, folks, what we at CREW tend to do about all this is we believe that in social network and social capital, it is clear, as one of my co-panelists mentioned, Hajar mentioned earlier, that there was this 1995 disastrous heat wave in Chicago, 739 people died. But there's also a book out by sociologist Eric Klingenberger, and he essentially pointed out this is the 1995 social autopsy of the Chicago heat wave. And essentially what he pointed out, sisters and brothers, is that people who had connectivity and who were connected to each other had was the greatest indicator of survivability. So that really points out another point that I want to make. Bishop Desmond Tutu, a South African Anglican, said that my humanity is bound up in yours, for we can only be human together. And essentially, it is this very premise, based and rooted in the love of others, that we at CREW are trying to help connect people in the localized communities to develop what we like to refer to as a CREW team. And really the essential purpose of this CREW team is that when the storms of chaos do come, and when the floods of confusion do rise, and when the extreme weather does hit us even more on a disastrous level, those who are most vulnerable in our community, the elderly, people of color, low-income communities, who are disproportionately impacted by the effects of climate change, folks will have other folks in the community checking in on them, doing a wellness check to see if they're all right. And essentially, that's how we are going to, I believe, get through this pandemic. Yes, we need to practice social distancing, and yes, we need to listen to the CDC, but essentially, I think in order for us to get over to the other side of this thing, I think that people have to realize that we're in this together. And then once we realize and recognize that we're in this together, then united we stand, divided we fall. Then we can come together and we can therefore reduce the transmission of COVID-19, because we have this mindset that we're in this together. We have this mindset that Bishop Desmond Tutu said that my humanity is wrapped up in yours, that we're all tied in the inextricable garment of mutuality, as Dr. King said. And essentially, what we're here, why we fought to put this event together, is because we want to highlight, yes, there is a connection between infectious disease and climate change, but at the end of the day, that if we can bind together, and if we can connect, and if we can come together, black, white, and brown, people of faith, people of no faith, people of goodwill, people of moral conscience, come together, and then we can begin to tackle these substantial problems that exist in our world today. And I think, and then I'm almost done, and I think that this is an opportunity, COVID-19 is an opportunity to create some new norms, to challenge racism, and challenge environmental devastation, and challenge greed, and challenge hatred of the other as we come out and as we're progressing closer and closer towards a vaccine, which some say might not be from anywhere from 12 to 18 months. But I think we should use this opportunity to focus on, as they say, the proverb they say in Africa is, "I am because we are." I know in Western society, some of us have this mindset from taken from Rene Descartes. I think, therefore I am. But I think once we start to enlarge our scope and replace I with we, then I think we can make some substantial progress in tackling these challenges that this crisis is laying to bear. Thank you. Thank you.
Thank you.
Amen. Amen, Reverend Walker. We have some questions that have been brought up that seem to be a lot of interest in the actual science of this. I've actually taken to listening to this show that's on every week. It's a really strange show, but if you look it up, it's actually very, very informative. It's called This Week in Virology. And it comes out every single week, and they discuss things that you read about in the New York Times a couple of weeks later. And in one of these things last week, they talked about, why is it that bats are so important in the transmission of this? And the transmission Apparently it's because bats are the only mammals who fly. And so, but in any case, these are interesting things. But one of the questions that we got was, could you explain more about how the origin of viruses and how the changing relationship between humans and the natural world are releasing viruses? I would guess that goes to Dr. King.
Okay, thanks. All organisms are afflicted by viruses. Mammals, birds, bacteria get viruses, bacteriophages. And normally, the viruses are very highly tuned to the organism, to the cell that they're growing in. They're adapted to, and they can't grow in another organism. But at some low frequency, an event occurs where you do get a bat virus getting into humans. Might first get into some other organism, cats or dogs that the bats have interacted with. The flu is a good example. So ducks have flu viruses, chickens have flu viruses, humans have flu virus. Almost all birds have flu viruses. And flu, the chromosome has many different pieces. Like humans, we have 23 chromosomes. Influenza has 9 to 11. And so occasionally you have a situation where a duck flu gets into a pig, or a pig flu into a duck, and they exchange their chromosomes, and you get out a variant that now turns out can propagate in humans. So the more we have unnatural interactions between human populations and the wild populations, and also domestic, millions and millions of ducks and pigs and chickens very, very, very close together in industrial food supply. It's an increasing danger.
And could you also explain again the issue, when another question came up, about the changing in bird migration and how that impacts this?
That's interesting. Henry David Thoreau was a great naturalist, and he logged at Walden Pond and the gardens out there in Concord, which are still there. You can still visit it. He logged every spring when various species of birds arrived, and so we have a record, 150-year record of bird migrations. It turns out that that many species that visit those sites in Concord now arrive a few weeks earlier. But the insects don't migrate, right? So the pupation, the emergence of the insects stays as it is. So those things are out of whack. The birds have a problem because when they do arrive, there aren't insects to eat. And then the insects are not, their population is not controlled. No one has yet studied infectious disease transmission from those populations. It's a subject of naturalists who are worried about the birds.
Well, thank you very much. So the big question is, so we know a lot about what is going on, and this may be a good opportunity to ask for a fundamental change in policy, and how do we do things differently? I know that there's a lot of talk out there. Well, a lot of the meetings I go to talk about, well, how are we going to change things going forward? So how do we change things? Who wants to give it a try? All right, I'll call on you then. Robbie Goldstien, give us a try.
I was going to say, I'm happy to take the first shot at that. I think one of the more important things that we have to do, and this is something that the Infectious Disease Society of America has called for, and many other physician organizations have called for, has been a huge increase in the funding to our public health infrastructure, to our research organizations, so that we can be prepared for what we see coming down the pipeline. I think if we look at what's happened with COVID-19, we heard already about the defunding of public health over the past decade tonight. I think we have to recognize that defunding of the public health infrastructure also meant that people who are actively working to identify the next novel coronavirus, the next pandemic that was going to hit, were taken off of that research and defunded and put onto something else. It left us quite vulnerable. We have now seen that this will happen and it's going to continue to happen. And so the number one thing I think we can do from the federal government perspective, at least, is to really shift our resources into the basic science we need, the public health that we need, the adaptation that we're going to have to put in to all of our emergency response systems so that we can include an infectious disease pandemic as part of the next potential natural disaster that may affect us all.
That sounds like something that might require us to vote in November. So hopefully we are still enabled to vote in November.
Can I add something to that? I absolutely agree. You know, most Americans, they learn in high school that, you know, we have elected officials, and they learn that elected officials write the laws. But often they don't learn anything about budgets, right? We Americans have been sending their income taxes to the federal government for more than 100 years, and no agency of the federal government has ever communicated back how that money is spent, right? And so this key aspect of the nation's morality, how they spend the money, and the most important thing determining policy, is kept under wraps, right? You ask the average American how much of their taxes goes to the military, they'll say, oh, 10 or 15%. When you tell them it's 60%, they say, I don't believe you. The state budget, a little more transparent because there is an actual website. You can look up how much the state is going to spend on transportation and public health. But the state website doesn't tell you that 30% of the state budget comes from federal funds that are transferred into the state. In the area that Robbie works in and Bill lives in, I live in 7th CD, thousands and thousands of graduate students, research technicians, postdoctoral fellows, hospital technicians are paid by federal funds coming back into Massachusetts. And most people don't know about it. They think graduate students pay MIT. They don't realize, no, the taxpayers pay the graduate students, the other way around. But those personnel are absolutely critical for preparing us for the future.
Thank you. Vernon, maybe you could also discuss in your comments about what do we do about the fact that we just see continuation of really poor outcomes for low income and people of color, and the kinds of things that maybe should be on our list of things to do to ensure that we at least start moving in a better direction.
Yes, well, I think it starts with a fundamental realizing and recognizing that not only is our humanity bound up into in each other, but I think that for folks who might live outside communities of color, we know that communities of color are disproportionately hurt by climate change and climate impact. I think for folks who might live outside of those towns is to figure out ways in which solidarity can be built. Figure out ways in which support can, a coalition can be multiracial, multifaceted, multicultural. And I know it's more harder to do and it's more harder to get done in reality as it easier to say it in rhetoric. But I really think it starts with a fundamental idea that I want to look up the organization in a given community that's working on the ground, that's working in a grassroots capacity to help build an equitable and just society. And obviously at CREW, we do that in some ways, but I think that if we're going to make a systemic and a radical change, I think this realization that public health is connected with the economy, is connected with so many other areas that these are all interlocking. You know, I oftentimes say that if people who benefit from environmental devastation who benefit from unjust systems, who benefit from the war on the poor, who benefit for those who are in poverty, who benefit from racist structures in society, who benefit from the defunding of public education, who benefit from climate change, are sinister to get together and to come together, then I think for people who are fighting for a just society, a more just and equitable society, ought to be smart enough to come together. And I think really what that looks like is folks who do environmental work, connecting with folks who do anti-racism work, connecting with folks who do anti-militarism work, and folks who do indigenous justice work, really coming together and figuring out and seeing the connection that our issues are connected. For example, if you fund more, if you take away funding from the social programs on a federal level and you give more to the military budget, but then the most vulnerable are hurt. And oftentimes the most vulnerable are also hurt by extreme heat, because those who live and suffer from an urban heat island effect often don't have access to an air conditioner or to an AC unit, and now they're stuck in a hot apartment or a hot house dealing with the urban heat island effect, which can make things 6 to 7 degrees hotter in some communities, and it kind of exacerbates the issue, which therefore leads to higher negative health consequences. So I hope I answered the question.
Yeah, thank you. I can tell you that I went to a lecture, this must be like 15 years ago now, from the Public Health Commissioner of Seattle, Washington, who put up a bunch of slides on maps of Seattle, during which he said, well, this is where diabetes is located. And then he said, well, this is where the crime rate is higher, and this is where obesity is higher, and this is where the fundamental problems, they were all the same exact map. And so we don't think systemically in our society, and therefore we wind up with these systems that don't work for populations that desperately need it. And so overall, I think what we've all been saying here is that we need a fundamental change in the way that we approach these issues. We have just a few more minutes, and what I would like to do is ask people on the panel if they would just have kind of walking out of here, what do you recommend to the people that are listening? What do we do starting tomorrow?
Could I speak for a moment?
Yes.
Okay. I'm working on a new form of transportation that will totally change the emissions so that we can have the same kind of clean air that we're getting right now. It is affordable by all of us, no matter what your income is. And there's a bill in the legislature. We will be attaching it as an amendment to one of the 3 job creations bills. I'd like to talk to Hajar and Reverend Vernon so that you know about this and can share the information. The website is Bay State Sunway, SUNWAY, and I'll get to you. Okay, thank you.
Sure. So final comments by our panel?
Well, our representatives in the state legislature, at least some of the most progressive ones, have been fighting in the state legislature to get the state to do all that they can. The thing that they've gotten furthest on is protection from evictions and renters' protections from being kicked out, and homeowners from being foreclosed or mortgage. Mike Connolly's been a leader in that, and Nika Elogardo, and they need our support, right? So you can write to your state rep and state senator and tell them, you want these protections passed in both houses of the legislature, and if the governor vetoes it, you want him to override the veto.
Comments? Vernon?
Okay. Then maybe we can ask Hajar to come. Just want to share, we would love to work with you from a crew perspective. We stay nonpartisan. We don't necessarily endorse the particular bills in the House. We have one of our sister program that does a lot of that. Two of our sister programs, 350 Mass, and also the Divest Ed. But we love to work with you to figure out what developing a climate resilient agenda in your community look like, a localized climate agenda. And we love to work with you. We love to connect with you. We love to figure out, what are some of the challenges in your community in regards to people connecting. Obviously, we're in this pandemic and a lot of people are home, so it may be easier to reach out to folks. So, from Crew's perspective, we really love to connect with you where you are. Our goal is to create sustainable and inclusive climate resilient communities across Massachusetts. And we're working with various folks who are more on the front lines of political advocacy, but we ourselves try to stay nonpartisan as much as we can, because we'll work with Democrats, we'll work with Republicans, we'll work with Black, we'll work with white, we'll work with brown, we'll work with Lottie Dottie and everybody. We'll work with anybody that's willing to say, let us figure out how we can connect.
Thank you. Amen.
So can I speak to that also? So I concur completely. I think Vernon and I, like Reverend Walker and I, are very aligned in our approach in politics. It's really important that we work together and that we all have something to add. We all have not just perspective, but resource and expertise to add to a solution that covers the entire city and the state, and we need to work together to deliver on that. Thank you for sharing. I think it's, say it again, Boston Way, Sunway. Can you put it in chat so that I can follow up with you? Also, in terms of the bills, we have similar sister organizations that do the public policy work. We do some educational work as well. And when I say we, I'm affiliated with an organization called Alternatives for Community and Environment, and they do that work. That's kind of how I know Crew. And we are building climate resilience conversations around air pollution and around public health and public health impacts and transportation especially. And building policy and community organizing simultaneously. And so we want all policy to be guided by community voice and experience. And we want community voice and experience to also be reflected in the academic work and creating the right climate models and making really addressing the condition and the situation in a way that's inclusive and collaborative. So thank you so much for volunteering. And like I always say, we can't do anything alone.
Thank you. Johnathan or Robbie?
I'll maybe just add one comment at the end here, which is I think something that we will echo what we've all been speaking about, which is really how interconnected so many of these issues are. This is a panel about how climate change can impact an infectious disease. And I think we have to remember that climate change and healthcare and transportation and education and housing and all of the different pieces of our government, all the functions of our government are all interrelated. And so it's not enough for us to just fight for one piece of that. We have to actually fight for all of them at the same time so that we can make sure that we're keeping communities safe. So we can make sure that not only are we providing everyone healthcare, but we're making sure that they can go home to a healthy space. So I think we've all been talking sort of to that point about the interconnectedness of so much of what we're discussing.
Thank you. Johnathan?
No, I would second that. I just want to point out that it does cost money. It doesn't need government. It's not enough to just come together, right? You have to have a policy goal right? You have to have a direction, what it is that we're going to change, right? And we want Medicare for all, right? We have to deal with the fact that that's a government congressional policy decision. Loving each other won't get us Medicare for all. It's a battle. And there are people who are opposed to that, the private health insurers, et cetera, right? So we have to recognize we're in a fight. We need a real strategy. We need some real goals. And, you know, we have to work together to achieve them.
Yeah. So I'll just finish off by saying, by quoting Barney Frank, actually. For those of you who remember, Barney Frank was the congressman from Massachusetts for many, many years. And I remember me talking to him once about how, oh, there isn't any money for this on the budget. And he said, don't ever let anyone fool you into thinking there isn't money. It's not about how much money you have. It's about how you spend the money, because the government can create money when they want to spend it. And if they decide that it's better spent on healthcare than it is on armaments, that will result in more money for healthcare. So I just want to finish with that. Just realize when people tell you, oh, we don't have the money for that, they're lying. Thank you very much and have a great evening.
Thank you.
All right.
Thank you, folks.